We're back again with topic 4, electronic fetal monitoring. Let's go ahead and get started on how we monitor our babies in mom. Okay, you know about the electronic monitoring from Skills Day and the components that are involved in electronic fetal monitoring. And for those of you that have already started your OB rotation, you have seen moms put on the monitor, you've seen the devices that they use, and the pieces and elements that come together to make electronic fetal monitoring. Remembering you have an ultrasound, that is the flat surface that the gel is applied to transduce the fetal heart rate of the baby to the monitor. That goes on the portion of mom, typically the lower segment of the abdomen, if the baby is vertex, cephalic, or head down. All of those are interchangeable words. And if the mom is in a breech position, if the baby, I should say, is in a breech presentation, then the ultrasound will typically go in the upper portion of the abdomen, depending on the location of baby. Then you have the TOCO, which is used to monitor contractions. Just a reminder, the external TOCO does not measure the intensity of a contraction. It simply measures the frequency and lets you know when a contraction is occurring. The internal devices that are used for electronic monitoring are the fetal scalp electrode, or FSE, that is put on via a vag exam. Baby has to be head down in order to place that on the scalp, and we demonstrated that in skills. And the IUPC, or intrauterine pressure catheter, is the internal device that measures the contractions that mom has. The IUPC measures the intensity of a contraction because it takes that pressure in the uterus and measures it and allows it to be read via the electronic fetal monitoring system. Okay, so those are the components of the electronic fetal monitoring system that you will use and that you will see in the labor and delivery unit. Electronic fetal monitoring is fairly new. It's only been around since the late 50s. Before that, we were using the fetoscope and the Doppler, and those were our means of knowing that a baby's heart was still beating, and that was all we knew with that. With the electronic fetal monitoring, we're able to learn whether or not a fetus is compromised or not. We're able to assess fetal placental exchange. We're able to know whether or not a fetus is being oxygenated properly. So the fetal monitoring system developed the ability for us to really see whether or not this baby was being oxygenated properly, whether the placenta was working well with the uterus, and these things were taking place that told us we were working with a baby that was compromised or a baby that was doing well. Okay. The first thing that you're going to look at when looking at a fetal heart rate is the heart rate, the baseline of the heart rate. What is going on with that baseline? The baseline is the average line on your monitor that you see when you're looking at that fetal heart rate. At the very top of your fetal monitoring paper is the baseline of the baby's heartbeat. The fetal heart rate is controlled by the autonomic nervous system and is inhibited by the vagus nerve. So you have the two parasympathetic and sympathetic nervous system, those two components working together to provide you with a reading of what that baby's heartbeat is doing. When you have a stimulation in the vagus nerve, the parasympathetic, you have a slowing that occurs in the heart rate. When you have that sympathetic nervous system taking over, that stimulates activity through the peripheral nerves, and contractions will occur, causing an increase in the fetal heart rate. So the parasympathetic slows the heart rate, and the sympathetic nervous system increases the heart rate. So you have that push and pull of the heart rate that goes up and goes down. That pressure that's occurring in that heart that lets you know that this baby has a good heartbeat. When pressure rises in the carotid and the aorta of the heart, that heart rate goes down, causing a vagus response. When that pressure decreases through that beating of the heart, that heart rate goes up. So you have what we call the push and pull of the parasympathetic system, controlled by the parasympathetic and sympathetic system, all under the autonomic nervous system. Okay. So we talked about the devices that you would see in electronic fetal monitoring. Non-invasive are those that go on the outside. Invasive are those that go on the inside. When looking at a fetal heart rate strip, when looking at the paper that is used to monitor a mom, the first thing you're going to want to look at are the lines and what is measured on each line. You have here the numbers here, 60, 80, 100, 120, 140, 160, 180, 200. That represents, the arrow represents here a 5 beat per minute range, okay? So when you count, you're going to count for hold on one second. So you're going to, I'm sorry, I had to pause for a minute. You're going to count, if you look at, let's start right here at the 120. If you look at the 120 in the middle there, and you go to that next line, that's going to be considered 125. So you have a 5 beat per minute range there. 125, 130, 135, and then 135 to 140 gives you a 5 beat range, okay? Then when you look at the second area that represents 1 minute of time, the thick blocks represent 1 minute. This paper here is for an older machine. So the paper that you'll see in the hospital is going to look a little bit different and will be a little more obvious, and so you can count that. But that a full block that you'll see on your screen or on your paper represents 1 minute. You should be able to count 6 small blocks in that 1 minute block, giving you 60 seconds or 1 minute. Then at the bottom, this bottom area, this bottom block here represents the contractions. This is where you would see the contractions, mom's assessment. What is mom's uterus doing in relation to the fetal heart rate? So this represents 10 millimeters of mercury. The line here that has the arrow going to it represents 10. So if you start at 30, you go 30, then the next line would be 40, the next line 50, and 60. 60 would be this line here, okay? So that represents 10 millimeters of mercury, okay? All right. So again, it's probably going to be a little bit clearer on the strip of paper that you'll have in the hospital, and I'll bring that so we can go over that in class, because this piece of paper is not as accurate. So when looking at the fetal heart rate, you're going to look at the baseline heart rate first, okay? You're going to look at the baseline of the heart rate. So the baseline, if you were to take a piece of paper, right where you are on this strip of the screen, take a piece of paper and go across your screen with the edge of the paper. And if you look at that, you'll see a line that is pretty straight along your edge of the paper. And it's difficult to see, but if you look where the 120 is, that next line should be 130, okay, that the heart rate's baseline is on. So you would say that wherever the majority of your line falls would be considered your baseline. So this baseline would be about 130. That would be the fetal heart rate baseline. The next thing you're going to look for when looking at a heart rate is looking at whether or not it falls within normal. So we know that the baseline for a fetal heart rate on a fetus should be between 110 and 160. So if we say this baseline is 130, then we know it's falling within a normal range, okay? We'll get to accelerations a little bit later. If it is not between 110 and 160, if it is lower than 110, that is not normal. That's considered bradycardia. If it's higher than 160, that is not normal. That's considered tachycardia. So those are areas that you'll want to address, and we will talk about them as we go further into our lecture, okay? So when looking at fetal heart rate, after you assess the baseline, let's go over here. Everything that comes on the baseline you'll look at, but I just wanted to introduce contractions right here because the contraction pattern is important when looking at the rest of the strip and whether or not there are accelerations and decelerations. So let me just pause on the fetal heart rate and jump right here into contractions and kind of round it out again for you as we come to the rest of it. Uterine contractions, remember, are the primary force when looking at the 5 forces that we talked about in topic 2. That's the primary force that comes with helping to deliver a baby. The maternal pushing is the secondary force that accompanies a contraction in helping to deliver a baby. So when looking at contractions, you're going to look at 3 areas, and we kind of talked about it and touched on it in topic 2. How often are they coming is the frequency, how long are they lasting is the duration, and how strong are they is the intensity. So we're going to look at that and measure that every time we look at a fetal heart rate strip. If you have a contraction pattern that is having 5 or less contractions in a 10-minute window, an average over 30 minutes, that's good. If you have more than 5 contractions in a 10-minute window, you're looking at a tachysystole pattern, which means you're having too many contractions over a 30-minute window time. And then as you look at that, you then look at what the baby is doing, your heart rate, what is this doing in relation to contractions? So that's the piece that I kind of wanted to introduce as we talk about fetal heart rate, because the contraction pattern will impact what the baby does in response to the uterine contractility. Okay, so now let's go back then to the fetal assessment. We talked about a baseline of 110 to 160 being our normal baseline for a baby in utero, and anything that is above, let's look at tachycardia. Anything that is above 160 is considered tachycardia. Now, there are many causes that can come from a baby whose heart rate is greater than what is normal. That could be from hypoxia, meaning the baby's not getting enough oxygen, to mom having a fever, or the baby having anemia, or the mom getting a medication called terbutaline, or the baby having an infection in the chorion and amnion, the sac where the baby is housed. A baby who's premature can develop a fast heart rate as they compensate for the lack thereof, or a baby who has a cardiac dysrhythmia. Okay, these are all causes that could predispose a baby to having a heart rate that's greater than 160. Bradycardia, just the opposite. A heart rate that drops below 110 is considered bradycardia. Okay, these can be, again, related to problems with mom. If mom is having seizures, or if mom develops eclampsia, which is seizures that occur from an elevated blood pressure. If mom has hyperstimulation that results in the uterus begins to contract too frequently, then this can cause problems. Or maternal hypotension, mom's blood pressure dropping, can cause the baby's heart rate to drop, because as her cardiovascular system is impaired, that in turn impairs babies. Because remember, baby's circulatory system is operating through mom, so any impact to mom's circulation will impact baby's circulation. Of course, if the baby's cord is compressed, because that umbilical cord supplies that baby with oxygen, so any suppression of that cord could potentially cause the baby's heart rate to go down. And then a condition called placenta abruption, where the placenta begins to separate from the uterus. This is a very, very serious OB emergency that can cause a decrease in the baby's heart rate. Okay, so these are some things that we would note. Okay, so after you've looked at the baby's heart rate baseline, you've looked at it, 110 to 160 is normal. Anything greater than 160 is tachycardia. Anything less than 110 is bradycardia. These two can result from different disorders and disease processes going on in mom. They need to be assessed and evaluated. Once you've done that, then you can move on to the next assessment within the fetal heart rate, and that is the variability. Variability represents the irregularity of the rhythm within the cardiac rhythm of the sympathetic nervous system and the parasympathetic nervous system. Remember, we talked about that push and pull of the sympathetic and parasympathetic nervous system. So this beat-to-beat change that occurs within the fetal heart rate baseline is what we look at to monitor variability. And we look at typically a 10-minute interval on the monitor strip to measure the variability that that patient has. So when you're looking at the variability looks like the jagged part of the baseline. So it's the up and down portion that you see, or the seesaw, representing the beat-to-beat variation. Now, a beat-to-beat variation that is within 6 to 20 is considered a normal beat-to-beat variation. That's considered normal, and that baby's CNS, central nervous system, is intact. Okay? So that's one thing that you always want to note. Anything between 6 and 20 is considered a normal and intact central nervous system. So we'll get into how you look at that and what you do to measure that. Okay? So, looking at variability here, we have some examples. In the A example, A representing this first block up here that says undetected, this is considered absent or undetected variability. The line is straight. This is telling us that our baby's central nervous system is not intact. This baby, matter of fact, is probably acidotic and on its way out. So this is not good. When you see this on a fetal monitor strip, this is not a good response. This baby has to be delivered emergently. Okay, so absent variability is not good. If you go across there and hold a piece of paper up to that line and it's straight, that's telling you that this baby's in trouble. Okay, minimum variability. When you detect a less than 5 beat per minute variation, the way you would measure that is you take the highest portion of that height on that beat to the lowest portion. And if you get less than 5, because remember each block is a 5 beat per minute block, then you're at a minimum variability. Minimum variability can come when a baby is sleeping, or it can come when a baby's decreasing in its ability to oxygenate itself. Okay? So minimum variability is something that we will watch very closely. Moderate, this is the area I talked about that represents a good variability. This tells me that my baby is tolerating labor well, central nervous system is intact, baby's oxygenating well, the placenta is working well with the uterus, and my baby is doing okay. You see the difference in the way the monitor is reading from the absent and the minimal. Lots of variation, lots of beat to beat. You see that up and down going very high, and that tells me my baby is good. Marked variability is greater than 25. So you have a baby who is having an increase in variability. Sometimes this can be a baby that's suffering as well, or a baby that's compromised. This can come sometimes when you have a cord prolapse or you have a cord that's being squeezed. This can also result when you have a mom who's hypotensive or the placenta is separating from the uterus. So this is marked as something that we watch very closely as well, and we do further assessments to make sure that we are taking care of this baby in the proper manner. Okay, so if mom is having decreased blood pressure, then we're giving her medications to increase her blood pressure. If If she's having uterine hyperstimulation, if that uterus is contracting too frequently, then we're giving her medicine to slow down that contractility. If we have a cord prolapse, then we're getting her to the OR to get that baby out. So marked is something that looks like, oh, that's good, that baby's real happy. No, not necessarily. This baby could be compromised, and you definitely want to do whatever action is necessary to intervene on behalf of this baby. So you really want to look at a baby and see your baby in the moderate area. Minimal is okay. It can be that the baby is just sleeping and decreased variability occurs, and that's okay. Continue to monitor. Absent is a sick baby, and marked could potentially be a baby that's compromised. Okay, so that's how you would monitor variability. Okay, these are just some other things that could cause a decrease in the variability that's noted, and so you want to take note of that. Anencephaly, drugs, a vagal blockage from medications, atropine, and any type of cardiac defect or not a defect necessarily. It could be a cardiac defect. Yes, cardiac defects can cause decreased variability, but cardiac reduction related to a baby that's sleeping. Okay. Now you've looked at the fetal heart rate baseline. You've established what it is. It's within normal. It's not tachycardic. It's not bradycardic. You've looked at the variability. You've established you have a good variability. You're within moderate. Your baby is doing well. It's not absent. It's not minimal. And if it is, it's resolved back to moderate. It's not marked. Now you'll want to look at whether or not this baby is having accelerations. And acceleration is an increase in the heartbeat above the baseline. So if we establish that our baby's baseline was 130, then an acceleration would be considered a heartbeat that goes up to 145 and lasts 15 seconds or more. So an acceleration is defined as a fetal heart rate that goes up 15 beats above the baseline and lasts 15 seconds or greater. Okay, 15 seconds or greater. Accelerations can be associated with fetal movement. When a mom has a vag exam and the doctor touches that head, that stimulates a response that can cause the heart rate to go up. Sometimes contractions will cause that excitability that will cause the heart rate to go up. This is a reassuring sign within a fetal heart rate. Okay, when a heart rate goes up and you have accelerations, this is a reassuring fetal heart rate. Okay, and reassuring sign is something that is basic to a non-stress test, which is an NST. A non-stress test is when a woman comes into the hospital or comes into the office and is placed on the monitor for about 20 minutes and has at least 2 accelerations within that 20-minute period. That tells us that this baby has a reassuring non-stress test. Okay? So that's what an acceleration is, and that's what we qualify an acceleration to be. Okay? So this is just a picture showing you what an acceleration looks like during a contraction. Okay? So this baby is looking really good during the contraction, handling the contractions really well. Okay? The next thing you want to look at is decelerations. Now, there are 3 types of decelerations. The first one being early. An early deceleration represents head compression. That baby's head is being pressed or squeezed and causing an early deceleration. A late deceleration, meaning the baby is late to the party. Okay? A late deceleration is when the contraction occurs after the peak of a contraction. I'm sorry, I didn't tell you when an early occurs. An early will occur with the contraction, and it mirrors a contraction. And then you have a variable. A variable is when the cord is compressed. Okay, when the cord is compressed. These are the 3 types of decelerations. Now let's go into them. An early deceleration is pressure on that baby's head. This pressure, in turn, alters the blood flow and stimulates a vagal response. Remember, with a vagal response, you're always going to have a decrease in the heart rate. Okay, a decrease in the heart rate occurs, and that changes when that pressure is relieved. Okay, so recovery occurs right after that pressure is relieved, and that's an early decel. Early decels, again, they mirror a contraction, which means they start when a contraction starts and they end when the contraction ends. This head compression causes this vagal response, and they're very uniform in their shape. Okay, so know that earlies always mirror their contractions, and they're repetitive. Their reassuring head compression just simply means that the cervix is dilating. So earlies, we do nothing about them because they're good. They're telling us that this baby's coming down and that cervix is dilating. Okay, again, these are just pictures of earlies and what you would see on your monitor. Lates, on the other hand, are very different. Excuse me, watch the drink. Earlies, always think of earlies being okay because you always want to be early somewhere, but being late, that's never okay. So lates, what's happening with a late? The uterus uterus is having a contraction, the mom is having possibly a decrease in blood flow, blood volume causing hypotension. This decreases her blood flow. As her blood flow decreases, this fetal oxygenation is decreased. Fetal hypoxia occurs and myocardial depression occurs. This activates a vagal response and produces a deceleration. Why does this occur? Because you have a mom whose uterus and placenta are no longer working sufficiently. So mom's placenta can become old. It can begin to separate from the uterus. She can develop an infection. She can develop some sort of disease process that causes the uterus and the placenta to not work together. And this insufficiency causes a hypoxic reaction to the baby. When this occurs, this is telling us that this baby's oxygenation level, this baby's acid-base level is becoming compromised. This baby is becoming hypoxic, and hypoxia leads to acidosis. Okay? So how does this one look? This one begins at or after the peak of the contraction, and it returns to the baseline, fetal heart rate baseline, after the contraction has ended. So the early, remember, mirrors the contraction. The late comes after the contraction. That's why it's considered late, because it comes after the contraction has peaked and ended. It returns after it has ended. Okay? Typically, these are repetitive and they're non-reassuring. So an intervention must take place for late decels. An intervention must take place. This is what a late decel looks like. Okay, this is what you may see on the monitor. You can see where the little long bars are representing where the peak of the late meets the end of the contraction after the contraction is ending. Okay, very subtle. That's why it's very important that you know and understand how to read a fetal heart rate. How to read a fetal heart rate strip is very, very key to the nursing care in L&D. This is the bread and butter of L&D, because without this, if you don't know how to read it properly, this is what ends up in litigation. When a patient has not been cared for properly, this is what will end in litigation. Now, let's go